So what were the governments trying to achieve? They were trying to achieve 5 things. I was part of the Commonwealth negotiating team at the time, and many of you were participating perhaps in the New South Wales side of things. Some of you I know have come from interstate. The Prime Minister in particular, her instructions to our negotiating team were to achieve transparency. Everyone in this room knows that the health system changes when it's transparent, when it's clear what is exactly happening in the workplace or at managerial level. And she wanted to bring that transparency principle to bear in funding terms. So she wanted to know exactly where every Commonwealth dollar goes in the health reform agreement to public hospitals. And she wanted to be able to say, and she will soon be able to do this, exactly where that Commonwealth money goes throughout Australia, which local hospital networks it goes to, and what do they do with that money, and how, what is the activity that's derived from the use of that money. I think everyone in this room knows about 40% of public hospital funding in Australia is derived from the Commonwealth. It varies in each state. Mary will correct me, but I think in New South Wales it's around 38–39%. So the Prime Minister and the Premiers and the Chief Ministers all agreed they wanted transparency, to know exactly where money goes in the system and what is delivered for that money. They wanted value for money, to know exactly a reassurance to the public that their public funds were well spent and value was derived from that money. The states and the territories, and with the agreement of the Commonwealth, I don't think this is a contested issue, wanted independence of price setting. So they wanted an independent process through which activity-based funding prices are set independent of government, and that led to the creation of the IHPA. They wanted national comparability, which is an important underlying principle. We get a lot of pressure in the IHPA for state-specific pricing regimes or territory-specific pricing regimes, but on the principle of national comparability and our Act, we've actually acted at a national level. And of course, all governments want efficiency, want a better outcome with the dollar for an output that is derived from the inputs that government supply. So we're part of a key efficiency agenda. So governments were looking for a transparent system that gave value for money and drove efficiency in the system, but yet was independently set in terms of pricing. The IHPA is part of that process. So I'll just briefly describe what we do, and then I'll turn to a little bit about where our work's up to a little bit later on. Our role is defined in the National Health Reform Agreement. It's reflected in our legislation, which is no longer under consideration by the Federal Parliament. That slide needs to be updated. It was actually passed in November last year. So our key role is to set the efficient price, and the legislation and the agreement specifically use the term the efficient price for activity-based funding in hospitals throughout Australia. So we've interpreted that as a single national price, and as I said, a lot of states and territories don't necessarily agree with that, but across the nation we have set, or we're about to set, a single national efficient price. We're also responsible for any loadings that we determine should be added to that national efficient price, or in the case of some factors, subtracted from the national efficient price. I'll come back to loadings a bit later on, and I'll be able to tell you a little bit of detail about what we're proposing. We also have to specify all the classification, costing, data and modelling standards, most of which have been inherited from a lot of work done over the last 14 years on the National Hospitals Cost Data Collection, but all of which require a lot of work in the next 2 years to refine their specificity and to improve their applicability in the workplace. We've noticed that application across the country is very varied, and to the extent that it undermines the quality of the data. So we'll be working with you, many of you at a hospital level, to improve the quality of adherence to national standards, but also in return on our side, improvement of the specificity of those standards. They're pretty general in some regards. We also have to determine the criteria for defining block-funded services. So hospitals in Australia can be either activity-based funded or block-funded, and we have to define the point at which hospitals become, or services become, block-funded or activity-funded, and we're currently in discussions with the jurisdictions about that point, but we have proposed a level for small rural hospitals, based on a New South Wales suggestion, I might say, of around 3,500 national weighted activity units. So above 3,500 national weighted activity units, hospitals will be activity-based funded in rural settings. Below 3,500, they'll be block funded in rural settings is what we're proposing. And we're in discussions with the states and territories in the Commonwealth about that. In metropolitan settings, we don't see a reason why any hospital, apart from specialist hospitals like mental health hospitals or rehab hospitals, should be anything but activity-based funded. So we're really, in metropolitan settings, seeing no reason why activity-based funding shouldn't prevail. We also have a funny role in resolving cross-border disputes and assessing cost-shifting disputes. So cross-border disputes are disputes between two states or territories, and the most predominant one here is the ACT New South Wales dispute, which is not necessarily in dispute right now, but it's always a matter of some discussion. And of course, the New South Wales, Victorian and Queensland cross-border flow issues. So we're a body that will be able to save jurisdictions time, effort, money by assisting in resolving those matters. And we do actually have a reserved power in the Health Reform Agreement and in the legislation to actually determine those cross-border disputes if so referred. We haven't got any referrals yet, thank you, Minister, but expecting one in due course. We also have a role in assessing, we don't determine, but we assess cost-shifting disputes between the Commonwealth and the states and territories, which is not yet been called upon, but I know that there are some states who've got some issues with Commonwealth cost shifting, and I know the Commonwealth has got some similar concerns, so in due course we'll wait to receive those matters before us. We don't determine those disputes, we assess them, but we also publish our assessment, so it'll be interesting when that comes about. So we will produce a national efficient price, a single national efficient price. We won't be producing a Tasmanian price, a Northern New South Wales price, or an ACT price. We'll be producing a national efficient price for these service lines, acute inpatients, emergency department services and outpatient services in the coming weeks. So we're in the final stages of iteration with jurisdictions right now, Commonwealth, states and territories. From the 1st of July next year, we also have to produce an activity-based funding system for subacute services and mental health services. Subacute services looks entirely feasible. Mental health services, major challenge. We really have to redesign the system from the ground up. Not the delivery of the mental health system, but the activity-based funding principles that underlie mental health funding. And we'll try and move as expeditious as we can with mental health, but it's going to be a big challenge.